Great. And I want to welcome everyone, and especially Melissa Rosen, who is here representing Sharsheret, which is a fantastic organization that we partner with and support every year, who offers education and support and resources for people who are going through breast cancer, ovarian cancer, families who are going through those terrible times, and also survivors. It's a tremendous organization, and I'll let her tell you all about it, and also to introduce our panelists. And we'll have time, everybody will stay on mute until the question and answer period at the end, at which time we'll have plenty of time for discussion. So please, Melissa.
Thank you so much, Rabbi. So my name is Melissa Rosen. I am the Director of Training and Education at Sharsheret, and we have an amazing panel here tonight. I want to introduce two additional speakers. With us, we have Sandra Abrams, who is a 2-year breast cancer survivor. And we're actually coming up on the 2-year anniversary of her diagnosis. In her other life, she is a professor of education, and she's going to share her story with us tonight. And we also have Dr. Emily Ambinder, who is a board certified radiologist and assistant professor of breast imaging at Johns Hopkins. Her research actually focuses on improving breast cancer detection with a focus on new technologies and public health. So the way we're going to work tonight is we're going to start by having Sandra share some of her story, and then Dr. Ambinder will speak, and I will wrap up with some additional information, including about Sharsheret resources. So I want to welcome Sandra and thank you again for joining us.
Well, thank you for inviting me. So I guess it's been a couple of years now. Well, it'll be 2 years as of November 1. That's when November 1st, 2018 was when I was diagnosed with microinvasive lobular cancer, breast cancer for that matter. And it was 16 days before my daughter's bat mitzvah. So it was pretty much a shock because I like to say that I live a healthy life. You know, I exercise, I eat organic foods, I go out of my way to do things that are green and organic and take good care of myself. But I think it's also because of that I was able to catch the cancer that I had early. And it really starts back to when I was in my late 30s and I thought I felt something, and I went for a mammogram and they didn't see anything because I had dense breasts. And then they sent me for a sonogram, and they thought they saw something, and they did a core needle, and it was nothing. And I was still kind of thinking to myself, well, they can't see anything. Why am I going for these tests? Which is really foolish, right? But I was trying to find the logic in it. So I was a very bad girl, and I didn't go for my mammogram when I was 39, and I didn't go when I was 40, and I didn't go when I was 41. Well, fast forward to 42, I'm speaking with one of my doctors who said, talk to me about your breast health. I tell her what I told you. And she said, well, what about an MRI? And I said, I can do that. She said, sure. I said, because my biggest issue was the logic of it. You can't see anything. So why am I exposing myself to the radiation? Even if it's a little bit, why am I doing it? And why am I potentially going for these diagnostics that may or may not work on me? So I get the MRI, which there are some questions as to why people get them, because they can lead to rabbit holes. But for me, I was very fortunate because the kind of cancer I had was only detectable by MRI. So, and especially at the stage it was in. And I found out I had to go for additional diagnostics, a fine needle biopsy that also pointed out something else that needed to get excised. I had a couple of core needle biopsies. I had an excision in late October, and they double checked and triple checked actually the results, because they couldn't believe it either, that it was microinvasive lobular cancer. And because the core needle prior to the excision showed that I had something called LCIS, or lobular carcinoma in situ, which actually is not cancer. it can lead to cancer, but it's not cancer. But it was the excision when they actually removed it and then they did the biopsy there that showed it. So I worked rather quickly. I met with, um, doctors from a number of hospitals, medical oncologists, as well as surgeons. And I opted to go for a bilateral mastectomy with reconstruction. And what really got me through this and helped me to make my decision that was right for me was speaking to people through Sharsheret, because I was able to hear other women's experiences. So what Sharsheret did was I called them and they paired me with people who had similar, not the same, but similar cancer. They asked if I wanted to speak with people who had had mastectomies or radiation and tamoxifen. And I said both, because those were my two options, by the way. I had two options, radiation and tamoxifen for 5 years, possibly 10, or I can get either single or bilateral. I went with bilateral mastectomy. And I also chose reconstruction. So I wanted to speak with women who had had bilateral mastectomy with reconstruction, as well as women who had had radiation and tamoxifen. And again, I want to stress that I did what was right for me. Everybody's cancer is different and everybody chooses what's right for him or her or them, depending on your pronouns. And it was really the generosity of people, survivors, providing me just details of their experiences, what they went through, mothers, because remember, I had a young, a rising 12-year-old who was just coming into her womanhood, and here I am losing my breasts. And that's what I thought was so interesting about it. And plus I had the bat mitzvah, and I have an older daughter who's 2 years older. So I had a rising 12-year-old and a rising 14-year-old at the time. And how do I support them? How do I support my husband? How do I keep it all together and keep myself in check? And it was actually just through the kindness and generosity of the survivors and the people who work at Sharsheret. I hope they get through it.
Thank you so much for sharing your story. And I actually want to ask you a question, and it a little different than the question I had planned on asking you, but the way you ended your presentation, you were wondering how you were going to support your daughters, how you were going to support your spouse. It's so interesting, but so many of the women that call Sharsheret are worried about supporting others, even though they're the one who's in need of support, which is something we're always pointing out to our callers. And so I guess I want to ask you to reflect for a moment on how support impacted you both for yourself and your family throughout your cancer experience.
Sure. So for me, it was, I just became resolute in what I wanted to, I knew what I wanted to do. And as a result, I felt confident in my decision because it was right for me. And that helped my confidence in my decision and that kind of strength helped me to kind of keep it together. That doesn't mean I didn't cry. It doesn't mean I wasn't sad and scared. I was all of those things. But I also received, literature in the mail from Sharsheret. I spoke to, I think it was Bonnie Beckoff at the time. She's still there from Sharsheret. I spoke to, would you call them counselors? I'm trying to think of their
social workers.
Social workers, right? So I spoke to them. I also spoke to other women who had children, and I asked, well, what do you do? And the truth is that there's no one right answer, right? It's hearing about what worked on their end and what didn't work. So if you were to ask me, I would tell you that my children didn't like the fact that I waited until after my daughter's bat mitzvah to tell them. I waited because I wanted it to be truly a magical moment for them, for my daughter and for her sister. And it was. And to see my daughter so happy at her bat mitzvah, I know that at the time she was upset that I didn't tell her right away. But I hope in retrospect, she will understand that it was really a gift to her because it was, it was a weighty decision. But it was just knowing how to be open and to talk about this. And just so you all know, this is the first time I'm actually publicly sharing this. It has taken some time to to talk about it, because there is this unnecessary stigma, which doesn't have to be, but there is an unnecessary stigma about it.
Yeah.
So does that help? Did I answer your question?
That's wonderful. And I know that in the past you've offered support on a one-to-one basis through Sharsheret like you received, but thank you. It's a very brave thing to be able to, you know, some people even say come out as a breast cancer survivor
Yes,
or things like that. So thank you very much.
thank you.
Okay, we're going to move to Dr. Ambinder, and then at the end, we'll see if there are any questions. So I'm going to take a second to share my screen because the doctor has a couple of slides she would like to share with you. Slideshow from the beginning. It's fine. And here we go. Okay. So let's just jump right in.
So I just want to thank you guys so much for giving me the opportunity to talk today. It's really an honor to be here today. I just wanted to start by talking a little bit about what I think all women should know about breast cancer. So to start with is just that breast cancer is really common. In the United States, 1 in 8 women will be diagnosed with breast cancer in their lifetime. It affects all women, all different races, all different backgrounds. And we know that family history of breast cancer is a risk factor, but actually 85% of women who are diagnosed with breast cancer have no family history. So that not having a family history is a little bit comforting, but knowing that 85% number, it doesn't make us feel that comfortable when someone doesn't have a family history, because we just know this is so common. So what should we do about it? As a breast imager, I am a huge believer in breast cancer screening. We recommend starting getting annual mammography at age 40 for women that are at average risk of breast cancer. And that's because we know that when we find breast cancer, when it's early, when it hasn't spread anywhere, patients do really, really well. There is a 5-year survival rate is 98% when we find breast cancer when it's in an early stage. And usually when we find them on screening mammograms, before a patient's even able to feel the cancer, it's going to be an early stage and very treatable. When we diagnose cancer at a later stage, the 5-year survival is much, much lower. This is that once it's already spread to other parts of the body, the 5-year survival is 27%. I know getting a mammogram is can be scary and it's not comfortable. I mean, I definitely recognize that, but it's a short period of discomfort that will really can find that cancer early and give you the peace of mind that the breasts are okay. We take generally 2 images of each breast, and that allows us to see all of the tissue in the breast in 2 different projections, so we can really understand where a finding is in the breast and whether it's something that's really concerning. When you get a screening mammogram, about 90% of the time, the result is normal. And that's great news that we say, we'll see you in a year, nothing to worry about. About 10% of the time, we see something that we're not sure about, and we want you to come back for some additional imaging. And I know that causes a lot of anxiety, which we totally understand. I know we try to get patients, we call patients and let them know that for all of the Johns Hopkins sites, and we try to get patients back in within a few days so that you come up with a final answer. When you come back in for additional imaging, we will either do additional mammographic images that can allow us to see findings in different ways, more specific ways than we did on those initial screening images. And often we also will do a targeted ultrasound of that part of the breast to see if we can see the finding with ultrasound. To reassure you, the majority of these screening mammograms that we call back turn out to be nothing, and we don't even recommend a biopsy. out of all of the screening mammograms that we do, only about 3 to 10 per 1,000 mammograms will have a cancer diagnosis in them. Of the ones that we call back, about 3 to 10% of them will have a cancer diagnosed in them. So even when you get that call back that you need to come back for additional imaging, it's more likely than not that at the end of your diagnostic appointment, the radiologist will tell you that everything looks okay. When we do recommend a biopsy, less than half of those cases usually turn out to be a breast cancer. So even with the biopsy recommendation, we do find a lot of things that are not cancers. So we get a lot of questions about digital breast tomosynthesis, or DBT. This is also called 3D mammography. And this is, it was approved by the FDA in 2011, and it was approved by Medicare in 2013. And since that time has really increased in how much it's been used. As a breast imager, I love 3D mammography for two reasons. So the most important one is that we find more breast cancers when we use this technique. There's been lots of different studies on this, but we usually quote that we find about 40% more breast cancers, and these tend to be the invasive, the worst, the more aggressive types of breast cancer. In addition, we are less likely to call a patient back for an abnormal screening study. And so you have those days of anxiety between the screening exam and getting that final result. That number of patients that have to go through that will decrease because we are more easily able to call a study normal when we use this. So at Johns Hopkins, we have this at all of our sites, and I think most of the groups in this area in the DC, Maryland, Virginia area have 3D mammography capability. And it's really appropriate for all women with of all different ages, all breast densities. But I will say it's particularly helpful in women who have dense breast tissue. It really allows us to see through that dense breast tissue much more easily. So just wanted to kind of go through some risk factors for breast cancer. And unfortunately, most of the risk factors for breast cancer are not things that anybody can change. So unfortunately, being a woman, you're much more likely to get breast cancer than if you're a man. As you get older, breast cancer, we know, becomes more common. There are certain genetic mutations that will significantly increase your risk of having breast cancer. Having early menarche or late menopause, that just means that you would have more years of having menstrual cycles and more years of estrogen on your breast tissue. That increases your risk of breast cancer. Having a family or personal history of either breast or ovarian cancer. Having previous radiation treatment to your chest or breast. It's not very common, but these are usually women that have had like a lymphoma as a child or a teenager that will get this treatment. And then finally, as I alluded to before, having dense breast is a risk factor for breast cancer. So speaking of dense breast, I know this is something that we talked about already tonight. So cancers can be harder to detect in women that have dense breasts. And that's because when we say dense breasts, that means that the breast has more fibroglandular tissue in it compared to fat. Those are the two components that we look at in a mammogram. And the fibroglandular tissue is white. Unfortunately, most cancers also look white on a mammogram. So, sometimes we'll say it's like looking for a polar bear in the snow. It can be hard to see that polar bear. In a woman who does not have dense breasts, the background tissue is going to be more of a black or a gray color. A lot easier to see that polar bear when they're out of the snow and in the water and grass, and that's what it's like trying to find a breast cancer in dense breast tissue versus in more fatty breast tissue. But separate from just the fact that it's harder to see the cancers, we also know that dense breast tissue is an independent risk factor for breast cancer. So for some reason, women that have more dense breast tissue are more likely to form breast cancers. So you would, when you have a mammogram on the report that you get from your doctor, it will notify you whether you have dense breast tissue. And if you do have dense breast tissue, you may benefit from a supplemental screening ultrasound or an MRI. And the recommendations on this are not entirely clear, because we know we can find more things that don't turn out to be anything, leading to some unnecessary biopsies. But we also know we do find more cancers when we do these additional tests. So we recommend talking to your doctor, looking at what all your risk factors are, and seeing what's the most appropriate screening for you. So those are all things that you can't do anything about, but there are some ways that you can reduce your risk. And things like eating a healthy diet, exercising regularly, maintaining a healthy weight will all reduce your risk of breast cancer. In addition, we know that breastfeeding, not smoking, and limiting alcohol consumption can also reduce your risk of breast cancer. So there are some modifiable risk factors that you can take control of. So I also just wanted to briefly talk about women that are at high risk for breast cancer and what would we want to offer for those women. And specifically, we like breast MRI a lot. We know we can find more breast cancers on them. The current recommendation is to do a screening MRI for women who are at particularly high risk for breast cancer. And when we say high risk, that includes women who have a genetic predisposition for breast cancer. So for example, a BRCA mutation, but there are other mutations that are less common, but are associated with a high lifetime risk of breast cancer. Women who have had chest radiation as a teenager or a young adult. And like I mentioned before, this is often women who have had a history of lymphoma that was treated with radiation. And then the most common group of women that fall into this category are those that have a 20% or greater lifetime risk of breast cancer based on risk assessment models. There's a few different risk assessment models, and they take into account different factors, but the risk factors that we've already talked about are put into the model and will give you what your lifetime risk is. And if that turns out to be greater than 20%, then we would recommend having a supplemental screening MRI. And this is right now supplemental. So we would do this in addition to doing mammogram. We usually ask patients to try to time it and do 6 months apart. So you're never going 6 months without some type of imaging of the breast. So if you think you might fall into that category, when you read over those risk factors I talked about earlier, I would recommend talking to your doctor and having an official risk assessment done to see if you would qualify for a breast MRI. So that's all I have. Thank you so much for your attention. Happy to answer any questions that come up.
So thank you so much, Dr. Ambinder. I have a couple of questions.
Yeah.
First one is with regard to MRI, is there any case where a patient would go right to MRI without mammogram, or is it almost always have to go through a mammogram first?
So currently all of the guidelines are to do mammogram and MRI together. There have been a few trials recently that have suggested that in women, especially women with extremely dense breasts, that the mammogram may not add anything. Those have not made it to any official guidelines yet, but I think that could be coming, that if you have extremely dense breasts, like Sandra was talking about, where it can be very hard to read the mammogram because of that, the polar bear in the snow situation, that maybe that woman wouldn't benefit from the separate mammogram on top of the MRI. But there are some findings that we see better on mammogram, and one of them is calcifications that we don't see very well on MRI. And so that's the situation that I think people are a little bit nervous with not doing the mammogram.
Okay. And the reason it's important to make it to the formal guidelines is because there are often insurance issues that come along with doing something outside of formal guidelines.
Yeah, you know, there's the official guidelines, especially the USPSTF. It's the kind of the overall the United States screening guidelines. Medicare has to at least pay for that, and usually the other private insurance groups will follow what Medicare does. And so that is, yeah, that's definitely a driving force for this.
Got it. So another question, which is a little bit probably outside of your expertise, but I'd like to get your opinion on it. Lately, there has been a little bit of controversy as to whether breast exams are an important factor in, something that women should continue to do. And as someone who is constantly looking for breast cancer, I wonder what your opinion is of that.
Yeah, I think it's a great question. You know, I know that the current recommendation is not to recommend routine self breast exams, and that's because I think women will often, feel a lot of things and come up and lead to an unnecessary imaging. I will also say, as a breast radiologist, I see a lot of cancers that are diagnosed because a woman felt something. I think that getting to know what your breasts feel like is important, and even if it's not like doing a really thorough self breast exam on a very regular basis, I think kind of knowing what your breasts feel like, where you have kind of your normal lumpiness is important. And when you notice a change, then we want to know about it, and we would want to work that up.
Thank you very much.
Yeah.
So
I have a question.
Yes.
Yeah, I have a question. I'm more concerned at the present time with ovarian cancer. I have a very poor family history. 3 generations of ovarian cancer. I lost my sister at 36, my mother at 90, and then grandmother at 70. I myself had endometrial cancer, very early stages at 58. And I have 2 relatives that had breast cancer. I've had all the genetic screening that I know about. And my question really is if there's anything new. I'm not a carrier for the BRCA. I've had the Lynch testing, which is for ovarian, and I'm not a carrier for that. And I have 2 daughters, so obviously I'm concerned about their health. Are there any other tests out there, being that my family history is not good, that I should look into?
So Dr. Ambinder, do you want to take this or do you want me to take it? Whatever works for you. We could also tag team if you
Yeah,
have.
let's tag team on it. You can go first and let no, this is not my expertise, ovarian cancer. I can tell you like what I know about it, but
So one of the things that I was going to add in my presentation after Dr. Ambinder spoke was about creating a customized screening plan. And I think that's so important. She talked about a formal risk assessment, but one of the things that everyone should know is their family's cancer history. And you clearly know that. That's great. That information, along with your own health history, should be taken to a doctor, whether it's a genetic counselor, whether it's an OBGYN, whoever it is, and you should create a customized screening plan based on that information. It may be your doctor says, oh, you know what, based on what I know, you can follow the guidelines and start, at whatever age the government is currently suggesting and do an annual. It may be that your doctor says, you have a strong family history and that's not going to be enough for you. We're going to want you to start earlier. We're going to want you to do it more frequently. And that could be because of be a strong family history. That could be extremely dense breasts. And of course, part of this conversation with your doctor is deciding whether genetic screening is appropriate. You've obviously genetic screening. And what I'll tell you 2 things. One is that the field of genetics is changing constantly. And if you have a strong family history, but have not turned up any genetic mutations on your screening, you should be reaching back out to wherever you got screened or your genetic counselor every year or so and ask them, does it make sense for me to rescreen at this point? Have there been enough additions to the full panel, not just the BRCA mutations, that it's worth it to do it again?
Okay.
They may actually even reach out to you, but it changes. And I'll tell you one other thing. If there's a strong family history, and the same was true with ovarian and breast, if there's a strong family history and there are no mutations that show up, you still have to treat yourself as if you're a high risk person, and do all that you can do to catch a diagnosis early or prevent a diagnosis. I think some of the most difficult conversations are when results come back that there are no known mutations, and we have to explain to someone it's very likely there is a familial mutation, we just haven't discovered it yet. So in terms of your specific questions, that's what I would say. You should be reaching back out to your healthcare provider every year or so to see if enough additional tests
Okay, thank you.
to make it worth it.
Thank you very much.
Add?
That's good.
Yeah, that works.
I think that was great. That was fantastic.
Okay, fantastic. So a couple of other things, and I'll talk for just a couple of minutes, and then I want to see if there are any other questions. So one of the things I really wanted to say was that customized screening plan is so important. I want everybody who's on today's session to realize the importance of being proactive. You heard when Sandra talked about how she really was proactive about what she wanted, and that was potentially life-saving for her. I mean, maybe they wouldn't have caught it on a different test. You've heard Dr. Ambinder speak about being proactive about your screenings as well. And, here's the thing. So often as adults, we're so busy, right? We have work obligations and family commitments, and we've volunteered and we've done this and that it's so easy to put ourselves at the bottom of our own to-do list. And I want to remind you tonight that that's not acceptable, that you deserve the same care you would give a loved one or suggest to a loved one. And when I say this, I always see heads nodding, but every once in a while, I'll see somebody kind of slowly raise a hand tentatively with a but. So unfortunately, that's not enough for some people. Maybe fear is getting in the way. Maybe they're just busy and they don't see the value in it. I hope both Sandra and Dr. Ambinder have convinced you that there's value in it. But if not, I want to reframe it in a different way. When you care for yourself, whether it's going for your annual checkup, right? Once you outgrow a pediatrician, there's nobody who's ever said we don't need annual well checks anymore. And yet I talk to many women who only get healthcare when they're pregnant. That is clearly not acceptable. So when you go for an annual well check, when you make your mammography appointment and keep your mammography appointment, when you do all those things, that's a modeling behavior. In other words, how can your children, whether your children are 3 or 33, know that they're supposed to care for themselves unless they see you doing it too? How can your children, your grandchildren, your neighbors, your colleagues, the members of your congregation, whatever it is, know that it's okay and necessary to care for themselves unless they see people around them doing it? And so by doing that and not hiding it, saying, I made my mammogram appointment, I can't go for coffee, or I can't meet you on Zoom on Tuesday morning because I'm doing this important thing, or whatever it is, you're teaching other people that they should be doing the same thing. And that is a real leadership thing, and so very important. I mean, there isn't a person on this call today who would let a child's lingering cough go without a visit to the pediatrician. Yet women and men let lingering symptoms linger without doing something about it because they're busy or they're nervous or whatever it is. But we need to care for ourselves. One thing we didn't talk too much about tonight is the BRCA mutations. We definitely said that they increase risk. I just want to give you a couple of sentences as a primer on it. first of all, everybody has BRCA genes. The genes are the good guys. They help suppress excess cell growth, which is of course what cancer is. The problem is having a mutation. And by the way, we now know that BRCA mutations affect not only risk for breast and ovarian cancer, but also pancreatic cancer, prostate cancer, melanoma, male breast cancer. So we also know that men and women carry BRCA mutations and pass them down to their children, male or female, in equal numbers. So this just isn't a woman's issue, it's an everybody issue. Very important. And so it might not just be a history of breast cancer or ovarian cancer in your family that's important. In my own family, my grandmother had pancreatic, my aunt had breast, and my cousin had ovarian, all on my father's side. 5 years ago, there might not have been a connection made. Today, now we know that that did require me to get BRCA screening because of that. And by the way, it's not just BRCA, as it was alluded to. There are other mutations that raise risk, that they're not quite as common within the Ashkenazi Jewish community, and they don't raise risk quite as much, but it might be another mutation as well. And the last thing, and we're going through this very quickly, this is sort of like breast cancer on one foot. The last thing that I want to tell you about is just Sharsheret for just 2 minutes, and then we'll see if anybody has additional questions. So for those of you who aren't familiar with Sharsheret, although I know your congregation has a long history with Sharsheret and raising awareness, which is amazing, but for those of you who aren't familiar, we provide free psychosocial or emotional support to women and their families impacted by breast cancer, by ovarian cancer, or by a mutation or family history that might raise risk. And we do that in 2 ways. We do it with an amazing team of social workers and a genetic counselor that take calls every day to offer support, to listen to you vent, to answer questions or connect you to resources. And then we have a series of formal programs to help a woman and her family navigate the cancer experience. I will send some of this information to Adrienne, who will be able to share it hopefully tomorrow with you. Our programs are all confidential, individualized, and 100% free. And although we are a Jewish organization and offer culturally meaningful support, our programs have no religious agenda and are open to everybody. So that's important too. So I want you to keep in mind, if you have genetic questions, you can always reach out and make a free appointment for a free conversation with our genetic counselor. If you know someone who's been diagnosed and would benefit from support, definitely remember that Sharsheret is there and introduce them to us. And really, I want to be cognizant of the fact that the program is supposed to end shortly and encourage you to go to Minyan afterward. But right now, we do have a couple of minutes for questions, if anybody has questions for any of our speakers.
What are the current guidelines or suggestions for being screened on the upper ends of age 60 up?
That is definitely for you, Doctor.
Yeah, so the ACR doesn't have a clear cutoff age for when to stop screening. As long as you have an expected lifetime survival of 5 to 10 years, we recommend continuing screening. I think also it's important to consider whether you would pursue treatment. So if you think, if I was diagnosed and I wouldn't do anything about it, then I think it's time to stop getting screened. But as long as you're in a healthy enough and in a position where you would want that cancer treated, you think, you would be expected to live for 5 to 10 years, then we would continue to screen you.
Are those still annual or every 2
years? So the
Yeah.
American College of Radiology would still recommend annual. All of the different societies have slightly different recommendations, and some will have suggested going down to every other year, and some of them do have an upper age cutoff, but we tend to be probably the most conservative, and we would say we find the most cancers if we look every year, and we know cancer just increases in its prevalence as women get older.
Thank you.
You're welcome.
Any other questions?